coagulation, thrombosis instead of thrombosis. But look forward to it. Thanks very much.
Dear colleagues, Mike already mentioned that morbidly obese patients have a higher thrombotic tendency. They are more prone to surgical wound infections. And what's the problem? We have great drugs to treat and even to prevent these different morbidities. And one of the major problems is how to dose these drugs in our patients. Does obesity affect the pharmacokinetics? It does, and in a nutshell I will take you through some of these changes. Now the problem with a lot of our drugs is that most of the data that we have gathered were obtained from studies with normal weight individuals. So what they do is you eliminate the extremes of ages, the kids, the elderly, and the extremes of weight, the anorectic and the obese. And you perform your studies, and afterwards the results that you have found and the dosage recommendations, you apply them in children, elderly and obese. So you can feel already the problem coming. It's not that simple. Another big problem is also most of the package inserts, the dosage recommendations are based on a milligram per kilogram basis. So what kilograms should we use? If we're talking about water-soluble or fat-soluble drugs, and I will keep it very simple, for water-soluble drugs, the excess fat tissue, just ignore it. Ignore it like Vladimir Putin ignores the Ukrainian army. Just drop it, and you do your dosage on lean body mass. If it's a fat-soluble drug, then the volume of distribution will increase, and you will probably need to do the dosage more near to total body weight. Obesity also affects the clearance of our drugs, the liver clearance. Most of the obese patients have some form of fatty infiltration, so my guess would be metabolism in the liver will decrease. It's not true for a lot of drugs. The elimination pathways, the clearance is faster. For instance, for paracetamol, you need to have a higher dosage in obese patients. And concerning renal clearance, the glomerular filtration rate and the tubular secretion rates are increased in obese patients. It is almost like the early phase of diabetic nephropathy. Let's not forget low molecular weight heparin, the new oral anticoagulants, they have renal clearance, and renal clearance is more related to lean body mass. That's an important thing to remember. Protein binding, just remember this, certain types of antibiotics are bound to alpha-1 acid glycoprotein, and in doing so can affect the unbound fraction of these drugs. One of the solutions in trying to do the dosage in morbidly obese patients, there are two strategies. Or you just reduce the dosage. Instead of 2 milligrams, you give 1 milligram per kilogram. Or you use a dosing scaler. You don't use the real body weight, but some adjusted forms. And here are some candidates. Body surface area, BMI, ideal body weight, lean body weight. The use of total body weight, one of the problems in the package inserts is that a lot of the medical firms think that the pharmacokinetic parameters are linear. In other words, somebody of 120 kilograms has double the volume of distribution of a 60 kilo person. It doesn't work like that. In other words, total body weight has the chance of overdosing your drugs. Body surface area, you know, a lot of toxic drugs like chemotherapy are dosed on body surface area, can be very dangerous. A nice, peculiar thing about these formulas for body surface area are based on 6 patients, these formulas. BMI, the problem with BMI, it does not differentiate between fat and muscle mass, as witnessed by this fat lady trying to get out of a swimming pool compared to this Russian athlete with a BMI of 46. can perform really Olympic performances. One of the earliest adaptations in dosing, using a dosing scaler was the introduction of ideal body weight. This is a term derived from the insurance companies, and strangely enough, the first application of this ideal body weight was in the dosage of gentamicin, an antibiotic. And in this way, it found its way in our dosing strategies. There are different formulas of ideal body weight. An ideal body weight is practical, up to a certain BMI. And I give you an example. For instance, a female patient weighing 168 kilograms with a height of 160 centimeters versus the same height but with a lower weight. If you use ideal body weight, you just do the dosage on 55 kilograms. In other words, it does not take into account changes in body compositions. How to resolve this? Well, add some fat. We've discarded the fat. We realized maybe it is important, so we will add a little bit, 20 to 40% of the excess overweight. Lean body mass. Lean body mass, the use of lean body mass would be more logical. Why? Because it's devoid of almost all the adipose tissue. The lean body mass, that's where all the metabolic activity occurs, and lean body mass correlates very well with cardiac output and metabolic activity and clearances of our drugs. Lean body mass equations, the most frequently used one is the James equation, and mathematically there is a flaw in that equation. And it was Mr. Jan Mahasatian who introduced this formula, and this formula is really based on morbidly obese patients using a dual energy X-ray absorptiometry. These formulas are much more better than the old James equation. So that's in a nutshell, I think, what you should know about obesity and its effects on pharmacokinetics. How to translate some of these things we've seen into the practice of dosing anticoagulants and antibiotics. Those of you who were expecting to get some clear-cut dosage recommendations, I have to disappoint you. They are hard to find. The dosing strategies, the administrations, it's a jungle out there. And it really makes me wonder how our patients keep from going under. There are even some publications that question the use of systematic chemical prophylaxis in morbidly obese patients. The American College of Chest Physicians regularly update their guidelines, their recommendations on the treatment and prevention of thrombosis. And this is one of the latest, published in 2008. And there are some recommendations, but no clear dosage guidelines. They're very blurred when it comes to giving practical advice. So let's go into some details. Unfractioned heparin. The pharmacokinetics are non-linear, and fortunately it's not distributed in the fat tissue, and probably total body weight is the most important predictor of the anticoagulation requirements. Just to give you an idea, in the year 2000, the recommendations were 3,500 units of heparin every 8 hours, and a recent study formed by one even increased the dosage, 7,500 units in a subcutaneous dosage every 8 hours. This is for the prophylactic use of unfractioned heparin. For the treatment, a lot of studies stress on the use of total body weight. Total body weight, of course, with pharmacodynamic monitoring using APTT and other measurements. Loading dose should be based on ideal body weight with some extra weight. There are also nomograms available. This was one of the earliest published by Mr. Raschke. What about low molecular weight heparins in morbidly obese patients? They do perform better. The benefit-risk ratio is more favorable. Be careful, in renally impaired patients, you need to reduce the dosage. We have the ability to monitor the anti-10 effect, although This testing is expensive. It's about €60 per test. And if you target a anti-10A level, it should be within the range of 0.2 to 0.5 units per milliliter. These are commonly used low molecular heparins in Belgium. And the current practice, usually one dose fits all. You give 30 milligrams, 40 milligrams, in this case of enoxaparin. Some other centers use a double dose of naproparin. Some centers will cap the dose, will limit the dose. But it is a fact, underdosing with low molecular heparins in obese patients is an epidemic, is an entity that we have to take care of. And when I try to look for dosage guidelines, this is what I came up with. In the prophylactic use, some studies advise to use a 40 to 75 international units anti-10A activity per kilogram total body weight once daily. Mr. Lutescu advised to use a 30% increase in normal dosage and maybe a longer duration of prophylaxis. If you have the ability to measure the anti-10A levels, these are the recommendations. Some studies, most of the studies focus on enoxaparin, and for instance, the use of 40 milligrams was more effective. There are some publications using body mass index, and strangely enough, the higher the body mass index, the higher the dosage that was given. And with this technique, 74% of the patients reached the therapeutic target. A recent study by Mr. Rondina showed that 0.5 milligrams per kilogram enoxaparin based on total body weight yielded therapeutic levels. What about the use of lean body mass? I found one publication on this topic, and I'll be very, very brief on this. This is probably in future we will see more studies introducing the concept of lean body mass in the dosage of our anticoagulant drugs. Now, for the treatment of thrombotic events, these are the guidelines. Use total body weight. Until further information is available, a once daily dose should be avoided in high BMI groups. For dalteparine, for tinzaparine, we have some studies that give advice on this. Capping is not needed. Now, the new oral anticoagulants, and these are some of the new drugs that we have. Some of them are direct thrombin inhibitors, others are direct 10A inhibitors. I can be very brief on this. The manufacturers advise to use fixed dose in normal patients and in overweight patients. But, and I think the next slide is a case report of the use of dabigatran in an obese patient who developed an ischemic stroke, and the authors were able to take some plasma levels, and they were sub-therapeutic. So probably the one dose fits all for the new agents will be not sufficient. Antimicrobial agents, I'm going to be very brief, and I'm going to focus only on the prophylactic use of antibiotics. In the Sanford Guide to Antimicrobial Therapy, there are some recommendations, and for a lot of antibiotics, there is some literature out there. But when I focus on cefazolin, 2-gram dose resulted in adipose concentrations similar to those as in normal weight patients, but 2 grams is advised. Some studies used a fractionated dose, 1 gram before induction, 1 gram after induction, yielding also similar fat concentrations. This is a study on cefazolin in morbidly obese patients, where a 2-gram dose was compared to a 3-gram dose, and the authors concluded that 2 grams was sufficient even for the super obese patients. And again, a study on cefazolin and its relationship to lean body mass, and you notice that in this study a fixed dose was given, and the anti-10A levels were measured, and it turns out that the lean body mass is probably a better descriptor for the pharmacokinetics of a molecule like cafezole. So if I have to come to a conclusion, unfortunately, there are some studies, but with no clear recommendation or guidelines on dosing anticoagulants and antibiotics. Of course, further research is needed, and hopefully we will see some studies in the future focusing on, for instance, lean body mass. I do thank you for your attention, and I give the word to our moderators.